All right, here we go. We're going to be moving forward with the second half of our lecture to replace the November 5th in-class experience. We're first going to start talking about anxiety disorders. And anxiety disorders make up their own little axis in the DSM, and we're going to be talking about mood disorders and anxiety disorders and then thought disorders. So anxiety disorders are very, very common. We see them across most age ranges, and they have a wide degree of dysfunction associated with them. So let's talk about what exactly is an anxiety disorder. Some characteristics of these anxiety disorders: motor tension, being jumpy, visibly trembling, inability to relax or calm down. Sometimes these anxiety disorders are sort of represented in hyperactivity or excessive movement. That fits also with being jumpy as well. Apprehension, that's more of an emotional state, whereas we can visually see motor tension and we can obviously experience hyperactivity. The apprehension piece tends to be less visible and is more internal. And this apprehension is that really important piece when we talk about distress. We're definitely going to see apprehension sort of fit that D in our criteria for abnormality or dysfunction. 5 types of anxiety disorders. Now, there are very many subtypes within these general types. So the first one is generalized anxiety disorder, post-traumatic stress disorder or PTSD, obsessive compulsive disorder, often referred to as OCD, phobic disorder, and panic disorder. Obsessive compulsive disorder is the disorder that we're going to focus on. Very quickly, though, generalized anxiety disorder is this sort of pervasive sense of dis-ease and concern with aspects in the environment, uncontrollable aspects, controllable aspects. Post-traumatic stress disorder, one of the hallmarks of this disorder is that there has to be a traumatic event. Now, in no other disorder do we sort of qualify it with a singular episode, but when we talk about vets returning from war, oftentimes PTSD is not associated with any one incident, but that state of heightened responsivity, especially over a longer period of time. So that sort of branch or continued experience can be that traumatic experience. Another very important note with traumatic stress disorder is that not a lot of people are aware of is that oftentimes there is a delay in symptoms. Like a vet may be returning, or a rape victim may return to her life, and life may be normative, and things may be moving smoothly. They may be able to be productive and get things done in their life. Oftentimes there will be a minor, less significant event that would actually trigger these symptoms of post-traumatic stress disorder. Anywhere between 6 months and sometimes up to 2 years post-event we might see this. But what we do in diagnosing this is we kind of do a retrospective account, and we look back to see sort of what event is sort of the impetus for all of those symptoms the individual might be experiencing. Phobic disorder, these are the phobias. These are, fear of spiders, fear of, claustrophobia, small spaces. There, you name it, and there is a fear for it. It meets the diagnostic criteria. Fear of the sun, fear of water, fear of money, fear of bunnies, fear of, literally, you name the entity, the object, or the concept, and there has been an identified reported case of it. Now, we might all be a little afraid of something, and in many cases that's fundamentally imperative to our survival, is to have that fear. In order for it to be considered a disorder, we have to see that distress, that deviance, and that dysfunction. So being afraid of something is one thing, but actually having a phobic disorder is something else entirely. And then we also have panic disorder. Panic disorders are when we think of like an anxiety attack or a panic attack. Panic disorders oftentimes are not associated with any one event. It's just a heightened physiological response, where when we talked about the sympathetic nervous system, the individual automatically is like defaulted into that sympathetic activation, that excessive response and reaction of fight, flight, or freeze. We are going to focus on obsessive compulsive disorder. Now, OCD, it's an anxiety disorder characterized by two components, obsessive thoughts and ritual compulsions. Now, some people just have the obsessive thoughts, but most people, most individuals with this disorder actually have ritual compulsions. Now, if an individual has obsessive thoughts and we still see deviance, dysfunction, and distress, you have to see that these individuals are really impaired and sort of stuck in a quagmire, with the inability to move forward and move beyond fixations and ideas and thoughts. The DSM order criteria, obsessions, which are those thought patterns, and then compulsions, which are behaviors that an individual participates in. And those obsessions and the compulsions, they must be recognized as excessive and unreasonable. You go out to your car, you get in your car, you're like, oh, did I lock the front door? You might get out and you might check your front door. Totally reasonable. To spend a half hour doing that after you've confirmed already, that's excessive. Interestingly enough, if an individual has OCD, depending upon what type of OCD, if you look at this picture here, you'll see that things are ordered neatly and nicely, and then one thing is set askew. Individuals with obsessive compulsive disorder would see that one thing and would fixate on that. And they would fixate on that with an obsessive thought, and then they would participate in the compulsory behavior of actually having to rearrange and situate that pencil so it fits straight. Obsessions. We're going to focus on obsessions and then we'll talk about compulsions. Obsessions occur repeatedly, and by repeatedly I mean almost on a continual running tape. Sometimes they need to be queued up, oftentimes with an interaction with somebody or seeing an object or hearing a certain person's voice, but typically obsessions can just cycle through without having any cue whatsoever. They are uncontrollable, and that the individual, once beginning this period of thought patterns and this process of thought patterns, lack the capacity to actually moderate or control how that is represented. They are unwanted and that they are intrusive. It being unwanted is sort of the piece of the distress that we're talking about with this disorder. Having unwanted obsessions are ones in which we can't control, and so the individual feels that distress because they lack the capacity to be able to moderate that or take care of themselves in that respect. They are anxiety provoking, and by anxiety I mean not just like, ooh, I'm anxious thinking that, but actually having that physiological activation that we talked about in our Unit 4 content when we talked about that sympathetic arousal, having that activation of body, perspiration, respiration increase, heart rate increase, stress hormones released. They're also disturbing, and they might not be disturbing as far as the content, but the intensity of them can be disturbing. Typically they're negative. People who have this disorder are not obsessed with things that are very positive. They typically are very negative, and getting stuck in that cyclical thought pattern of negative thinking and that obsessing can really, really be disturbing and disorienting. And finally, they interrupt life. This was that deviance, this was that dysfunction and that maladaptation. Very important in that these obsessions, these thought processes, these inter sort of dialogues are keeping an individual from being able to participate in those daily functionings and having that, what's the word I'm looking for? The capacity to be a responsible, productive member of society, and that this individual's ability to engage with others, maintain employment, maintain proper hygiene, all of those things might be affected by these cyclical thought processes that keep the individual from being productive or meeting expectations. Some common obsessions, the fear of contamination. We see this in chronic hand washing. Individuals might wear a mask, they might wear rubber gloves, they might be constantly washing their hands. Losing control, that for those individuals, they like to maintain, they like to be the one to drive everywhere. They, would want to be in control of their own faculties at all times. They wouldn't allow other people to make decisions for them. Harm to self, harm to others. These individuals would be anxious about having guns in the house. I'm anxious about having guns in the house. Oh, please go away. Sorry about that. So, we all might be anxious about one thing, but for these individuals, harm coming to themselves or coming to their family. Now, again, these are not actual things happening. Oh, go away. These are things that are not actually happening, but these are those cyclical thoughts that we were talking about. Perfectionism, the straightening of the pencil, definitely fits with that. Appearance is very strongly related. Now again, we're still just in the thought patterns. We're not actually in the behaviors yet. We're still focusing on the idea that the individual would become very anxious and uncomfortable if they saw a desk or a stack of papers that was out of order. This individual might really feel threatened and have a hard time with dealing with that or staying focused on anything else. Unwanted sexual thoughts, these can be intrusive, not necessarily inappropriate sexual thoughts, potentially illegal thoughts or very sexually uncommon thoughts, but they could just be unwanted sexual thoughts. And the final one is others. I have students that have compulsory behaviors about counting, students that have to continually count objects when they're in the environment. That's another sort of example. Compulsions are the behaviors associated with this disorder. Most common manifestations of OCD are through compulsions. These are the ones that we actually see. Some individuals might be obsessive compulsive and we might never actually know it because they are just in their thought patterns and we don't see behaviors that impact or influence. They are a desperate response to anxiety. It's almost as if it's a tension release. They feel relaxed and they feel like that might be one way to sort of regulate their anxiety. For example, I saw an example once of a woman who had this constant sort of obsession with her mother being hurt. And she believed that if she did not participate in certain rituals or certain compulsions, that her mother could or would be harmed. And so she would, that was her obsession, was the thought process that her mother was going to come to harm. And then her compulsion or her way to sort of regulate that obsession would be to create these ways that she could sort of control her mother being harmed. Like she had to step on a certain number of tiles throughout the kitchen. She had to open and close a door a certain number of times. The pancakes could only be situated a certain way on the plate. And so she felt that by compulsively controlling these sort of physical aspects or aspects of her environment, she was able to manage that anxiety and those obsessive thoughts while also sort of having a ritual that she believed was reducing her mother's risk of harm. Compulsions are very time-consuming. I've used the analogy of trying to get out of the house in the morning and being concerned about things being locked and turned off. And this is very much the case in that it's very time-consuming, which obviously greatly affects an individual's capacity to manage their daily life and maintain responsible, productive behaviors and manifestations. These compulsions, they're a temporary solution. They're kind of an escape from those obsessive thoughts. It's sort of a decompression valve, if you will, for some people, where it builds and builds and builds, and those obsessive thoughts culminate and become very intense, and then finally they are excised during this massive release or participation in compulsory behavior. Definitely a temporary solution. They can either be behavioral or mental. Now, obsession is those fixed thoughts that we return to time and time again. Compulsions, if we look at those as being mental, that would be the compulsion to count things, That would be the compulsion to, in their mind, say, count or do multiplications in sort of managing their overall physiological arousal to sort of dampen that and take care of that. Some common compulsions. I've mentioned this before: washing and cleaning. Checking is another compulsion, getting out of the house and having to check the doors and the locks and make sure that everything was unplugged and all the lights were turned off. Repeating, the young lady that I'd seen an example of, she would open and close a certain number of times. If it closed or opened one more time than it needed to, she had to start that repetitive behavior all over again. Mental compulsions, counting, arithmetic, could be association makings or covering of hierarchies. Other common compulsions, organizational, needing to have everything balanced. They might have compulsory behaviors in kind of with the washing and cleaning, but not wanting to touch anything, so they might carry a tissue or a Kleenex or maybe even a cloth with them all the time so they wouldn't have to touch any doorknobs or engage in light switches or anything else like that. So washing and cleaning and checking, those are very physical. Repeating and mental compulsions, those are both internal. Some characteristics of this disease: OCD is more prevalent among youth males than youth females. We see this more in males as a ways to control some obsessive thoughts. In mid-adolescence, the gender ratio is about equal, and then when we get into adulthood, it's predominantly female. And you know what? This isn't going to change. We're going to see that women suffer from higher rates of diagnosed disorder. Now, one of our contentions in this field is that, does that really mean that women actually have this disorder more, or does it mean that women are just being diagnosed more? And one of the things that we're seeing is that for quite a while it was that women were being diagnosed more frequently because they were seeking help for mental health issues. We see quite a bit more of a balance now between the genders than we used to. So these statistics actually mean something, to see that shift from the gender ratio being males predominantly and then being equal and then switching to females predominantly. OCD first appears between 10 and 12 years of age. It might start off with something very simple: don't step on the crack or you'll break your mother's back. And then the individual that might have a propensity for this anxiety disorder might have that become one of their first focuses. Oops. Late teens and early adulthood, we start to see it increase quite a bit. We see it sort of stave off a little bit in later adulthood, but we see it generally in 10 to 12. If not, then we'll see it a little later. Once OCD develops, it typically becomes chronic. Chronic is a pretty important word when we talk about mental health disease and disorder, and it's because chronic means that the course is negative, means that without treatment, without serious intervention, it's just going to either stay the same or most likely get worse. One of the things that we run into is that with obsessive compulsive disorder, if, for example, the young woman who was obsessed about harm coming to her mother, and then she participated in these ritual compulsions to protect her mother from harm, and then her mother comes to no harm, for her that's very reinforcing. It tells her that those rituals actually work. And so what happens is that each time her mother does not come to harm, it's a reinforcement for her. It's kind of like a negative reinforcer. You know, that potential bad thing doesn't actually happen. And so that negative thing is removed, and it increases the likelihood of the behavior happening again. Some statistics: about 1 in 100 adults in the U.S. currently have some level of OCD. It's not all clinical. They might be diagnosed, but it might not need to be medicated. At least 1 in 200 kids in the U.S. currently have OCD. Kids develop this as sort of a coping mechanism in order to manage their environment. And as you can see, based upon those numbers, it decreases by half into adulthood. And like I said, when we see things sort of taper off, that's what we're seeing there. So to sort of give it some perspective, in the average sized elementary school, you'd have 4 to 5 students with obsessive compulsive disorder. In a medium to large high school, you would have 20 students with obsessive compulsive disorder. Sorry, I'll turn back. I know that you can pause this, but it's very nice to be able to spend a little bit of time on the slide and follow the lecture naturally. All right, so how do we treat it? What are we going to do? Well, quite a few things we can do. The best treatment, though, of course, is this combination treatment of cognitive behavioral therapy. CBT was just something that you're going to hear about. It is the most commonly used therapy. It seems to be the most successful therapy because it packs sort of a 1-2 punch. We deal both with the obsessive component, the cognitive component, and then we also deal with the compulsory component or the behavioral component in dealing with obsessive compulsive disorder. Cognitive suggests that we're working on mental processes, thought patterns that sort of get you into trouble, and then behavior is the actual manifestation. Now we might work in one of two ways. We might say, all right, let's focus on changing our behavior first, and then we can use, focus on the thoughts. Typically therapists, approach both cognition and behavior at the same time. It is much easier to change behavior once we shift cognitive thought processes. It's very, very helpful when we do that. When we talked about operant conditioning and classical conditioning, and we talked about breaking sort of learned understanding and learned bonds, one of the things that we can do to change an individual's expectations or associations is to change that relationship. See if we can sort of back ourselves out of that behavior or that issue. And by back ourselves out of, I mean, if, say, for example, the young woman whose mother, she's obsessed about her mother coming to harm, and so she participates in ritualized behavior. If we actually stop the ritualized behavior and we see that her mother is still okay, that might be one way in breaking that bond, in breaking that connection that's there. Exposure response prevention is a type of cognitive behavioral therapy. This would be where, let's say, the individual has, their obsession is about contamination and their compulsion is washing or cleaning. And let's say, excuse me, let's say that they are concerned about being contaminated by doorknobs. And what we might do is we might actually put them in a hallway. Let's say we put them in the hallway up here by my office. We have lots and lots of doorknobs and handles on my floor. And we might say, all right, you have to walk through and you have to touch each one of these, but you do not get to participate in any of your rituals. You don't get to wash your hands. You don't get to do any of that. You have to just sort of expose yourself and then, not participate in those compulsory behaviors. Now, for some of you, you're like, well, isn't that kind of counterintuitive, Kim? Because don't we want to wash our hands after we get germs on it, from touching door handles that other people touch? And of course, we're going to want to wash our hands. But individuals with this disorder don't just want to wash their hands. They want to parboil their hands. They want to put a chemical on their hands that, peels their skin off. And they don't just want to go into the sink and wash their hands while singing the ABCs and get their full 20 seconds in of good hand washing with nice sudsy water. They want to scrub their hands with Clorox for no less than 10 minutes. And I'm being what sounds like a little facetious, but I'm actually being pretty sincere in that this is not normative, hygienic care. This is not normal germ prevention. This is extreme. This is very extreme, and it's very harmful for that individual. So very important that we keep that in mind. Medication, antidepressants typically used in the treatment of obsessive compulsive disorder is very, very helpful for them. We could go into the biology of it. We could talk about serotonin and we can talk about dopamine. I prefer to stay away from, again, the getting mired in the biology. And we will talk a little bit about neurotransmitters. But the important thing to note is that these antidepressants don't really, for the most part, give your brain anything more than it already has. It changes your brain's access to those balancing chemicals that are already there. 7 in 10 benefit with treatment, both behavioral and medical. Now, when I said that this was a disease or disorder and that we did actually see some biological changes, that's one of the reasons why we talk about medication. The cognitive behavioral therapy can deal with the psychology, but there's also a biology component, especially with the individual having OCD for an extended period of time. That's changed their brain chemistry. And in order to rebalance that or get that homeostasis back that we talked about when we were discussing motivation, in order for us to get that homeostasis back, we have to help rebalance those chemicals. 7 in 10 individuals with OCD benefit from this combination approach of both medicine and cognitive behavioral therapy. Unfortunately, I don't know if it's unfortunately, but it seems that we now really understand that these are medical issues because typically medication is the most successful route, and then any psychological component that we add in addition to the medication helps with quality of life and helps with recovery. But the medication can actually be very, very effective in and of itself. Cognitive behavioral therapy, OCD symptoms are reduced by 60 to 80%. And then for cognitive behavioral therapy to work, a patient must actively participate in treatment. And sometimes people get very comfortable in their own sort of disease or their disorder, and they would much rather stick with the familiar than branch out and risk themselves by participating in or experiencing something that is unique. And so this active participation is fundamental for success in all psychological therapies. About 1 in 4 OCD patients refuse to do cognitive behavioral therapy for that reason. For them, the ability to moderate and control their emotional states with these compulsory behaviors is very important to them. And they tend to be resistant to trying new ways because it gets to be comfortable. Exposure and response prevention, the ERP that we just talked about. While it is incredibly effective for breaking the association by showing the individual that your obsession and your compulsion actually have very little impact on the environment, it's important that the exposure and response prevention is done by a very qualified and trained individual. This is not something that you would want to try to attempt for your best friend without any medical assistance or clinical help, specifically clinical help. Well, as you can see, when I hit the button again, it's going to take us to the big black screen and tell us that we're all done. I hope, once again, that you've enjoyed listening to this. I still feel awkward. This is not my option of delivery. I look forward to seeing you on Wednesday. I'm glad that we were able to balance out my other campus commitments with at least replacing our lecture with this experience. I hope you guys have an awesome Monday, and if you're listening to this on Tuesday, a great Tuesday, and please don't forget to complete your participation.